We would like to welcome you to this beautiful venue, for which we would like to thank one of our members, Louise, who managed to organize this in such a beautiful space and such a secure space. I think you all feel very safe right now. To start tonight, I'm not gonna go very long with my intro. I would just like to say that we have a special guest with us here tonight, which is Dr. Ben Sessa, who will be the second speaker. And he's also one of the people who, let's say, kickstarted PSBE a little bit with one phrase, just go found the Psychedelic Society, which is the reason we are all here tonight. So thank you for that. I would like to welcome our first speaker, Dr. Geert Dom. He's a psychiatrist, a doctor, and he's also a professor at the University of Antwerp, I thought. So please welcome Geert Dom.
Yeah. So good evening, thank you very much. Is this clear? Like this? Because, okay, so we go ahead. It seems not to be my talk, but I'm prepared to give it. This is more my talk, okay. So thanks for the introduction. I'm a psychiatrist, so just to say something. And well, I'm really from the mainstream psychiatry today. As president-elect of the European Psychiatric Association, I'm deeply mainstream psychiatry, so I'm very happy to be here. My field of work is addictions for about the last 30 years, so I'm very, very curious to exchange, to hear. And I've been asked by Johan, thank you for the invitation. And this is the little title you gave me. Sorry, this is Flemish, but you said you can speak about 15-20 minutes, and I want you to speak about the current state of addictions in Belgium and what are the challenges and what we should do and what is the meaning of life. So I will try to do that in the next 15 to 20 minutes. First of all, welcome to Belgium. You know Belgium, we are quite good. We have a beautiful strips. We have at this moment a beautiful champion on cycling. I don't know what substances he uses, but it works. It really works. However, if we talk about the Belgium addiction care, so what are the strengths at this moment and the weaknesses? So I've tried to put it in one slide. And who works in addiction field here? Great. Okay, there's work to do for you Belgian addiction people. So, what are we good at? We have a lot of psychiatry beds. So cool, we have a lot of beds for addiction. We have, I think, a well-developed system of inpatient dual disorders clinics. I think above the level in Europe. I have a little bit experience in Europe. I think a little bit above the level. So that's cool. We are starting the last couple of years doing some community outreach, healthcare. Our outpatient facilities are lousy, really lousy, both in quality and in quantity. Our maintenance treatments are reasonable but not enough developed. So there's lots, and we have a huge problem with housing, supported work for our people. And we have a huge problem on doing research in addiction field, mental health, and surely in addiction field. And if you talk about research with psychedelic substances, it is really only beginning. So I'm happy, for example, my colleague there, Dr. De Stoop, who you can see now in the middle, yes, just to point some attention I have, is to try to start something with NMDA and depression and addiction, etc., etc. So we will need your help, man, to coach us to go further. And a lot of other problems is the integration with primary care from that field, the integration with somatic care for these patients, because we all know these patients with addiction die about 20 years earlier than they're supposed to die. So there's a lot of, and we have much more work to do in recovery and in the medications. Just the traditional medication. For example, naltrexone, well used in the UK, is not reimbursed in Belgium for alcohol. So not available for the alcohol patients. I don't know how it's in English with Buvidal. You know Buvidal, I don't know if it's reimbursed by the government for payment. Here it's so there's a lot of work to do, and of course if you talk about using other substances, there's still even farther. So lots to do in Belgium. If I look to what is to do the future challenges, let's say for addiction and a little bit broader, and this is not so clear, you cannot see it, but I presume these presentations will be shared by the organizers, correct? But I think what is coming the next years to us is, we see that of all the psychiatric diagnoses that you have, they stay stable in the population, stable. Not so much increase of depression, etc. The only cluster of diagnoses that increases in the population are substance use disorders. So that's a wave that is coming for the next years. Of course, a wave of also that these substances themselves are getting more varied, more available, more easy to get, and more different substances. And I think a problem also is a decreased tolerance in our society to accept problems related with substances, etc. Ending up, I don't know in England, but ending up in an increased level of patients with psychiatric problems and drug problems being in mandated treatment or getting put away or etc. So there is this decreased tolerance. We have problems with vulnerable children in the and so we have an increasing comorbidity problems that is to be expected. One of the hopes that I have for the talk afterwards here is that, well, we need to think about what we call transdiagnostic interventions. What can be used as psychosocial or medication or whatever psychedelics in the sense of it's worthwhile to find things to give people things of resilience for both psychiatric and other etc. And of course there's a better prevention problem, and I think I refer to this little book, probably Ben you know the author of the book because he has been the chair of the president of Royal College for a long time, and he's a famous professor, I think, in the UK, etc., etc. This is a very nice recent book about what will healthcare cost. For example, he made a nice calculation that if for the UK healthcare goes up at healthcare is about, I don't know, 12%, 14% of the global budget of England, rising 4% every year. So in 2040 or something like that, he calculated 99% of the global economy is going to healthcare. So no education anymore in the UK. Point 5. So, leaving me to switch to here, there's a lot to do. And one of the problems, and I make the bridge to the topic tonight, is, and I advise this article for everybody who wants to think about change. What is this article about? It is, why do we in the medical field, the broad medical field, so tend to keep doing what we are doing, often without evidence that it really adds? Why is it so difficult to change and to start to doing something else? For example, we know that doing an arthroscopy if you have arthrosis in your knees, so getting drilled in there and it doesn't work. While there are loads and loads of surgeons that keep on doing that. That's what we call low value care. Sorry. We do things, sometimes expensive, and we keep on doing things while the rendement is very low for the health. While other interventions, high value, but that you know that brings, and maybe Ben will talk about that later, it's very hard to change. It's very hard to go. So those who want to see what all kind of biases and barriers, etc., I really advise this article in Health Policy if you want to think about it and take ideas on how to influence and how to get any further. And we need to go further. Who doesn't know this little slide? Only 2 people do not know. Okay. It's a very famous slide from a very famous article from Stephen Lloyd, who once in the British Journal, it is published I think in 2012, and I think they're working for an update, calculated what is the effectivity of medicines in general medicine, and what is the effectivity of medicines in psychiatry. This is general medicine, and this is psychiatry. Maybe too complex or not for here. They use effect sizes, which is a common to express effectivity. What I want to communicate is that, first of all, the good news is the mean effectivity of drugs in psychiatry is exactly the same as the mean effectivity in overall medicine. So all doctors that come to me and say these psychiatrists don't know what you're doing, I always say, look at that. We know exactly, we are doing just exactly what you do from mean effectivity. And it is true. Yeah? The bad news is that this mean effectivity is really not so good. That's the bad news. It is not too bad, but it's really not too good. So there's a lot of room for improvement. What I mean not too good, that is, the effect sizes for this mean here are around 0.3, 0.4. What does this number mean? That is that you need to treat 9 to 10 patients to get 1 better above placebo. So there's a lot of room for improvement. Again, I hope that we'll see later in the evening, maybe some indications that some stuff can do it better. So, but we need improvement. So, the next challenge is, in psychiatry, do we really know what we are doing? Question mark. This is just published. Sorry to put all this science, absurdist science, this is in Molecular Psychiatry, published I think 3 weeks ago. Molecular Psychiatry is our top level journal in psychiatry with a big impact factor. This is a nice article saying our serotonin hypothesis for depression doesn't work, doesn't stand, we have no arguments. Psychiatry has been thinking like this for about 40, 50 years. It's a good article, but we should be critical of this article also. Yeah? So we tend to be a little bit simplistic, and the public, we are responsible for how public thinks also about psychiatry or mental health, etc. So really, it is my call to try to be not too simplistic, and not to try to use simplistic models of the brain or whatever explanations. Think critically, etc. And do we know what we are doing in psychiatry? Sometimes not completely. We do not understand really completely the brain, far of that, with or without psychedelics. We really don't understand it, so we have to be very humble, take it step by step, and try to do good science and good therapy, and try to be a little bit rational and mature. So what can we do to improve all this? First of all, if we say improvement, then we need to think, what should we improve? If a patient goes to a doctor with depressive complaints and the doctor prescribes something, whatever, what do you want to be achieved? Is that the depression feeling that goes down? Or do you want your patient to take up work? Or do you want to take up other outcome measures? So we need to rethink what are good outcome measures. Within psychiatry, traditionally, we think on this level as outcome measures. We are happy if our patients are abstinent. We are happy if there's a reduction of substance use. We are happy that there are less depressive feelings or anxiety feelings. Is that good enough as an outcome? Question mark. Or should you think about reduction of harm on all other levels? Or should you think of increased overall mental resilience. Is that a good outcome? Question mark. Or should you just ask the patient with patient-reported outcome measures, or what the patient himself or herself thinks that is relevant as an outcome measure? Or maybe just a fulfilling life. Is that an outcome of a treatment? Question marks. So how to improve? We can think about making better treatment much, biomarkers, etc. It's too short a time to think. So you end up in precision medicine, but then you need to really understand what's going on. You need a better understanding. Are we there in psychiatry? Sometimes a little bit. I think a lot can be said about early interventions, diagnostic approaches, new interventions, and tonight I think you, Ben, are going to talk about new old medications. That is one of the several possibilities to work towards improvement. And importantly, maybe we should think about combination of interventions. Maybe different interventions work together. Little overview, this is a slide I stole yesterday from Wim van den Brink, so please excuse me, but I have his blessing to do that. But he made this nice theory saying if you look the evolution of the treatment and research over this period towards 20, you see these trends going up and down. You see here in the early 70s with a lot of cognitive therapy, also a lot of rehabilitation, thinking. You see here the decade of the brain with a lot of pharmacogenetics, neuroimaging, a lot of animal studies also, so really the belief. And now we are more in this area here where you have increasingly again the recovery thinking as a trend, but also still a lot of animal research. And here you are with your psychedelic treatment. Here we are also with neuromodulation, etc. at the moment. So so you see these waves. If you're getting like me, I'm very old, so I see these waves coming and down and fading and up. So I started here. Well, no, not here. So I started something like here. I started my career, and I did a lot in psychotherapy in these days. So you have these waves, and then I did my PhD, which was on biological psychiatry, etc. So you go these waves. We all go these waves. This is a time for neuromodulation for other. Sorry. Yeah.
What's RAP?
Wellness recovery approach.
Okay.
It's a new trend, a new discipline. We need a broader recovery approach. Wellness is the outcome. I would like to be there. So precision medicine, I think this is the future. I think combination of interventions will be the future, or can be part of the future. Also prediction, but well, let's skip this slide. Predictive models can be, and I think for those who are familiar or not familiar with the work of Patricia Conrad and others, really early on children with vulnerabilities, early, so this is nice examples of early interventions. Giving young vulnerable children within the school context really coping skills and resilience specifically for their vulnerabilities, nice studies, good outcome, 2, 3, 4 years after intervention in the schools, no pills, effect sizes above 0.5. Nice, much nicer than the means before. And combinations, like for example, we know that neuromodulation can help your concentration, can help also your associative, can help give a boost to your memory. So maybe the combination of neuromodulation and talking cure and psychotherapy can have an enhanced effect, which is the same, by the way, if you use an NDA and you include talks, psychotherapy for your post-traumatic stress. It's a combination. So the combinations, I think, will become very important in the future. So let me slowly end. So I make now the curve towards Ben, and then I give over the word. So this is, I talked about all these several ways of possible improvement, and one of them is the use of this new, old. You again?
Just about the previous slide, is neuromodulation the same as neurofeedback?
No, no.
Okay.
Neurofeedback is you, for example, get an image of what is happening in your brain by, for example, EEG, and then you try by yourself focusing or doing a kind of a behavior to loop it back. So you get a bit information like, oh, this is the effect in my brain, and then if I concentrate and I pull, so you have this feedback. Modulation is, I put electricity on his head and do a little electric wave through his frontal cortex, or a little bit there, or magnetic stimulation, or rare cases, you drill in the head and you put something deep down, deep brain stimulation. Deep brain stimulation will not be the immediate future, unless in the UK they're thinking about other things, but it is neuromodulation, and that is already very widely used and commercially available.
Is it used and commercially available in Belgium?
It is commercially available globally. There are a lot of firms now, so also there you have to watch. You can buy it, you can buy the internet, it can be dropped in your place, it let a little casket. Watch it, don't order it, because I see now you immediately do not do it right away, but can have good effects. So one of the new old kids in town is the old medication, so I've been very curious, and of course we have all these traditions, very old and less old, etc., of ways of influences or way of thinking, etc. So and we know that, but Ben will talk about it surely. We have ketamine, for example, very recently, the boost again in the treatment of substance use disorders. We have ketamine, for example, anhedonia, and probably in the comorbidity, as probably Marianne's study will go. And of course, this article will maybe be next in the presentation, very recent, good outcome study with psilocybin and the treatment of alcohol problems. So there's a lot to do, and I'm very curious about really what is now the driver of the effects that we see. So my expectations for the next speaker, and I'm very curious. So Johan, you asked me a difficult question about the states of blah blah in Belgium. So now I'm at the finish. So I pass it to Ben and say, well, I'm very curious. What do these substances do, and how do they do it? And is this now medication effects, or is it basically psychotherapy? And the medication enhances the psychotherapy. If I'm a medical director of a hospital, so I need your advice. Should I, in my budget, put a lot of money for the staff, or should I put a lot of money for the substance? Don't say for the both, because I cannot afford so. What about microdosing, macrodosing? What about to expect? What are the outcome variables you're aiming at, or we're aiming at? What are the effect sizes? And what about, is this a kind of a transdiagnostic effect to be expected? If I have panic attacks and I have other problems, will this help me with all these problems? Which I would hope, because we in psychiatry tend to think a little bit of, we want one problem and only one problem. And so much more. So I'm very happy to pass to you, and I looked to your website, Ben, and it's fascinating, so I advise everybody to have a look at it and all the books and all the things and all the possibilities. Here you go. Thank you for your attention.
Thank you very much, Geert, for this lovely presentation.